Welcome to this video entitled, Pharmacotherapy of Asthma, Common Cold, and Other Pulmonary Disorders. Next we will discuss a few learning outcomes. After reading this chapter, the student should be able to accomplish the following. 1. List drug classes used for treating pulmonary disorders and discuss differences among their mechanisms of action. 2. Compare the advantages and disadvantages of using the inhalation route of drug administration for pulmonary drugs. 3. Describe the types of devices used to deliver aerosol therapies via the inhalation route. 4. Explain how drugs that modify the autonomic nervous system can be used to modify airflow in the bronchial tree. 5. Describe how drugs can be used to relieve the common symptoms of asthma, chronic bronchitis, and emphysema based on their underlying pathophysiology. 6. Describe the nurse's role in the pharmacological and non-pharmacological treatment of pulmonary disorders. 7. For each of the drug classes listed in prototype drugs, identify a representative drug and explain its mechanism of action, therapeutic effects, and important adverse effects. 8. Describe and explain, based on pharmacological principles, the rationale for nursing assessment, planning, and interventions for clients with pulmonary disorders. 9. Use the nursing process to care for clients who are receiving drug therapy for pulmonary disorders. The respiratory system is one of the most important organ systems. A mere 5 to 6 minutes without breathing may result in death. When functioning properly, the respiratory system provides the body with the oxygen critical for all cells to carry on normal activities. Measurement of the rate and depth of respiration and listening to chest sounds with a stethoscope provide the nurse with valuable clues as to what may be happening internally. The respiratory system also provides a means by which the body can rid itself of excess acids and bases, a topic that is covered in Chapter 53. This chapter examines drugs used in the pharmacotherapy of asthma, the common cold, and chronic obstructive pulmonary disease. Next we will discuss the physiology of the respiratory system. The physiology of the respiratory system involves two main processes. Ventilation moves air into and out of the lungs, and perfusion allows for gas exchange across capillaries. The primary function of the respiratory system is to bring oxygen, abbreviated as O2, into the body and to remove carbon dioxide, abbreviated as CO2, from it. The process by which gases are exchanged is called respiration. The basic structures of the respiratory system are shown in Figure 38.1. Ventilation is the process of moving air into and out of the lungs. As the diaphragm contracts and lowers in position, it creates a negative pressure that draws air into the lungs, and inspiration occurs. During expiration, the diaphragm relaxes and air leaves the lung passively, with no energy expenditure required. Ventilation is a purely mechanical process that occurs approximately 12 to 18 times per minute in adults, a rate determined by neurons in the brainstem. This rate may be modified by a number of factors, including emotions, fever, stress, the pH of the blood, and certain medications. Air entering the respiratory system travels through the nose, pharynx, and trachea into the bronchi, which divide into progressively smaller passages called bronchioles. The bronchial tree ends in dilated sacs called alveoli, which have no smooth muscle but are abundantly rich in capillaries. The extremely thin membrane of the alveoli separates the airway from the pulmonary capillaries, allowing gases to readily move between the internal environment of the blood and the inspired air. As oxygen crosses this membrane, it is exchanged for carbon dioxide, a cellular waste product that travels from the blood to the air. The lung is richly supplied with blood. Blood flow through the lung is called perfusion. The process of gas exchange is shown in Figure 38.1. We will now focus on bronchiolar smooth muscle. Bronchioles are lined with smooth muscle that controls the amount of air entering the lungs. Dilation and constriction of the airways are controlled by the autonomic nervous system. Bronchioles are muscular, elastic structures whose internal diameter, or lumen, varies with the specific needs of the body. Changes in the diameter of the bronchiolar lumen are made possible by smooth muscle controlled by the autonomic nervous system. During the fight or flight response, beta-2 adrenergic receptors of the sympathetic nervous system are stimulated, the bronchiolar smooth muscle relaxes, and bronchodilation occurs. This allows more air to enter the alveoli, thus increasing the oxygen supply to the body during periods of stress or exercise. Sympathetic nervous system activation also increases the rate and depth of breathing. Drugs that stimulate beta-2 adrenergic receptors to cause bronchodilation are some of the most common drugs for treating pulmonary disorders. When nerves from the parasympathetic nervous system are activated, bronchiolar smooth muscle contracts and the airway diameter narrows, resulting in bronchoconstriction. Bronchoconstriction increases airway resistance, causing breathing to be more labored and the client to become short of breath. Parasympathetic stimulation also has the effect of slowing the rate and depth of respiration. Pause the video and carefully scrutinize Figure 38.1 illustrating the respiratory system before advancing to the next slide. Next we will discuss the administration of pulmonary drugs via inhalation. Inhalation is a common route of administration for pulmonary drugs because it delivers drugs directly to the site of action. Nebulizers, metered dose inhalers abbreviated as MDIs, and dry powder inhalers abbreviated as DPIs, are devices used for aerosol therapies. The respiratory system offers a rapid and efficient mechanism for delivering drugs. The enormous surface area of the bronchioles and alveoli and the rich blood supply to these areas results in an almost instantaneous onset of action for inhaled substances. Pulmonary drugs are delivered to the respiratory system by aerosol therapy. An aerosol is a suspension of minute liquid droplets or fine solid particles suspended in a gas. Aerosol therapy can give immediate relief for bronchospasm, a condition during which the bronchiolar smooth muscle contracts, leaving the client gasping for breath. Drugs may also be given to loosen viscous mucus in the bronchial tree. The major advantage of aerosol therapy is that it delivers the drugs to their immediate site of action, thus reducing systemic side effects. To produce the same therapeutic action, an oral drug would have to be given at higher doses, and it would be distributed to all body tissues. It should be clearly understood that agents delivered by inhalation can produce systemic effects due to absorption. For example, anesthetics such as nitrous oxide and halothane, marketed as fluorthane, are delivered via the inhalation route and are rapidly distributed to cause central nervous system (CNS) depression. See Chapter 24. Solvents such as paint thinners and glues are sometimes intentionally inhaled and can cause serious adverse effects on the nervous system, or even death. The nurse must always monitor for systemic effects from inhalation drugs. Several devices are used to deliver drugs via the inhalation route. Nebulizers are small machines that vaporize a liquid medication into a fine mist that can be inhaled using a face mask or handheld device. If the drug is a solid, it may be administered using a dry powder inhaler. A dry powder inhaler is a small device that is activated by the process of inhalation to deliver a fine powder directly to the bronchial tree. Turbohalers and rotorhalers are types of dry powder inhalers. Metered dose inhalers are a third type of device commonly used to deliver respiratory drugs. Metered dose inhalers use a propellant to deliver a measured dose of drug to the lungs during each breath. The client times the inhalation to the puffs of drug emitted from the metered dose inhaler. Pause the video and carefully scrutinize Figure 38.2 illustrating devices used to deliver respiratory drugs before advancing to the next slide. There are disadvantages to administering aerosol therapy. The precise dose received by the client is difficult to measure because it depends on the client's breathing pattern and the correct use of the aerosol device. Even under optimal conditions, only 10% to 50% of the drug actually reaches the bronchial tree. A spacer can improve drug distribution to the lungs. See http://asthma.ca/adults/treatment/spacers.php. The nurse must carefully instruct clients on the correct use of these devices. To reduce the oral absorption of inhaled medicines, clients should rinse their mouth thoroughly following drug use. Two devices used to deliver respiratory drugs are shown in Figure 38.2. Next we will discuss asthma. Asthma is a chronic disease with both inflammatory and bronchospasm components. Drugs may be given to decrease the frequency of asthma attacks or to terminate attacks in progress. And now we will discuss the pathophysiology of asthma. Asthma is a chronic disease that has both inflammation and bronchospasm components. Treatment should focus on the reduction of inflammation. Environmental control can help to reduce inflammation and prevent asthma attacks. Asthma is one of the most common chronic conditions in Canada, affecting more than 2.2 million Canadians. The disease is characterized by acute bronchospasm, causing intense breathlessness, coughing, and gasping for air. Along with bronchoconstriction, the acute inflammatory response is initiated, stimulating mucus secretion and edema in the airways. These conditions are illustrated in Figure 38.3. Status asthmaticus is a severe, prolonged form of asthma unresponsive to drug treatment that may lead to respiratory failure. Typical causes of asthma attacks are listed in Table 38.1. Although the exact cause of asthma is unknown, it is believed to be the result of chronic airway inflammation. Controlling environmental factors that contribute to inflammation and asthma, such as dust mites and animal fur, may help to slow disease progression and prevent asthma attacks. Because asthma has both a bronchoconstriction component and an inflammation component, pharmacotherapy of the disease focuses on one or both of these mechanisms. The goals of drug therapy are twofold: to terminate bronchospasm during an acute asthma attack and to reduce the frequency of acute asthma attacks and prevent further airway damage. Different medications are usually needed to achieve each of these goals. A summary of the various classes of drugs used to treat respiratory diseases is illustrated in Figure 38.4. According to the Canadian Asthma Consensus Guidelines that were endorsed in 2003, the 5 fundamental aspects of asthma care are as follows. 1. Achieve acceptable control of the disease. 2. Treatment of asthma should focus on managing inflammation. Inhaled glucocorticoids are the first-line anti-inflammatory therapy. 3. Control the environment. 4. A written action plan for guided self-management should be provided for all clients. 5. If acceptable control is not obtained, other drugs can be used in addition to moderate doses of corticosteroid. Pause the video and carefully scrutinize Figure 38.3 illustrating changes in bronchioles during an asthma attack before advancing to the next slide. Pause the video and carefully scrutinize Figure 38.4 illustrating drugs used to treat respiratory disorders before advancing to the next slide. Next we will discuss beta-adrenergic agonists. Selective beta-2 agonists are effective at relieving acute bronchospasm. They are some of the most frequently prescribed agents for the pharmacotherapy of asthma and other pulmonary diseases. These drugs are listed in Table 38.2. We will now briefly consider NCLEX success tips. Salbutamol, marketed as Ventolin, is a rapidly acting bronchodilator and is the first-line medication in rescue inhalers that reverses airway narrowing in acute asthma attacks. Salbutamol, a beta-2 adrenergic agonist that causes dilation of the bronchioles, is prescribed to prevent and treat wheezing, difficulty breathing, and chest tightness caused by lung diseases such as asthma and chronic obstructive pulmonary disease, abbreviated as COPD. It's given by nebulization or metered dose inhalation and may be given as often as every 30 to 60 minutes until relief is accomplished. It opens and relaxes the airways, allowing a greater exchange of air, which is reflected as a higher peak expiratory flow rate. Irritability, nervousness, tachycardia, insomnia, and anxiety are common side effects of beta-adrenergic agonist bronchodilators that result from sympathetic nervous system stimulation. The expected therapeutic effect of a bronchodilator is decreased dyspnea and slower breathing. Fluticasone, marketed as Flovent, and salmeterol, marketed as Cerevent, is a combination drug used as a prophylactic agent to help prevent bronchial asthma attacks. The fluticasone is an inhaled corticosteroid that reduces inflammation. The salmeterol is a long-acting beta-agonist that reduces bronchospasms. The drug must be taken on a consistent basis, twice per day, over a long period of time to be effective. Salmeterol is a beta-2 agonist, a maintenance drug that the asthmatic client uses twice daily, every 12 hours. Salmeterol can be used to prevent exercise-induced bronchospasms, but it should be taken 30 to 60 minutes before exercise. If the client is taking salmeterol twice daily, it should not be used in additional doses before exercise. Twice daily is the maximum dosage. Indications for salmeterol include only asthma and bronchospasm induced by chronic obstructive pulmonary disease. If the client is ordered a bronchodilator and another inhaled medication, the bronchodilator should be administered first to dilate the airways and to enhance the effectiveness of the second medication. Advair Diskus is a combination of steroid and bronchodilator used in the treatment of chronic asthma and chronic obstructive airway disease. The medication is intended to be used daily. It is not a rescue inhaler, and additional doses do not improve respiratory function. Evaluation of effectiveness includes improvement in respiratory status and the ability to perform activities of daily living or quality of life activities such as walking and playing. Side effects of the medication include an increase in cough and sputum production. Beta blockers are contraindicated in a client who's wheezing because it's a beta-2 adrenergic antagonist. Signs and symptoms of salbutamol toxicity that the nurse should instruct the parents to watch for include tachycardia, restlessness, nausea, vomiting, and dizziness. We will now briefly consider NCLEX success tip. When using inhalers, clients should first shake the inhaler to activate the metered dose inhaler and then breathe out through the mouth. Next, the client should activate the metered dose inhaler while inhaling, Hold the breath for 5 to 10 seconds, and then exhale normally. Pause the video and carefully scrutinize Table 38.2 summarizing bronchodilators used for asthma before advancing to the next slide. Next we will discuss treating asthma with beta-adrenergic agonists. Beta-adrenergic agonists are the most effective drugs for relieving acute bronchospasm. These agents act by activating beta-2 receptors in bronchial smooth muscle to cause bronchodilation. Beta-adrenergic agonists, i.e. sympathomimetics, are drugs of choice in the treatment of acute bronchoconstriction. Sympathomimetics selective for beta-2 receptors in the lung have largely replaced the older, non-selective agents such as epinephrine because they produce fewer cardiac side effects. Sympathomimetics act by relaxing bronchial smooth muscle. The resulting bronchodilation lowers airway resistance and makes breathing easier for the client. A practical method used to classify beta-adrenergic agonists for asthma is by their duration of action. The ultra-short-acting drugs, including isoproterenol, marketed as Isuprel, produce bronchodilation immediately, but their effects last only 2 to 3 hours. Short-acting agents, such as metoprolol, marketed as Alupant, or cyprinoline, terbutaline, marketed as Bricanol, and perbuterol, marketed as Maxer, also act quickly but last for 5 to 6 hours. Intermediate-acting sympathomimetics, such as salbutamol, last for about 8 hours. The longest-acting agent, salmeterol, has effects that last for as long as 12 hours. The ultra-short, short, and intermediate-acting drugs act quickly enough to terminate acute asthmatic episodes. The onset of action for salmeterol is too long for it to be indicated for acute asthma attack termination. Formoterol, marketed as Foradiol, or Oxy's Turbohaler, is the newest beta-2 adrenergic agonist, combining a very rapid onset of action, 1 to 3 minutes, with a 12-hour duration. Inhaled beta-adrenergic agonists produce little systemic toxicity because only small amounts of the drugs are absorbed. When given orally, a longer duration of action is achieved, but systemic side effects such as tachycardia are experienced more frequently. These drugs are sometimes contraindicated for clients with dysrhythmias. Tolerance may develop to the therapeutic effects of the beta-adrenergic agonists. Therefore, the client must be instructed to seek medical attention should the drugs become less effective with continued use. Let's now focus on a few nursing considerations. The role of the nurse in asthma therapy with beta-adrenergic agonists involves careful monitoring of the client's condition and providing education as it relates to the prescribed drug regimen. Experiencing breathing difficulties can be distressing and greatly affect a client's quality of life. Controlling asthma is vital to a person's ability to perform normal activities of daily living. When beta-adrenergic agonists are used as bronchodilators, they help to reduce respiratory distress. Assess the client's adherence to medication and the presence of side effects. Assess for the presence or history of bradycardia, dysrhythmias, myocardial infarction abbreviated as MI, hypothyroidism, decreased renal function, diabetes mellitus, glaucoma, benign prostatic hyperplasia, and tuberculosis. Beta-adrenergic agonists should not be used if the client has a history of dysrhythmia or myocardial infarction. Drugs in this class may cause many undesirable side effects. For clients who are using isoproterenol, marketed as Isuprel, rebound bronchospasm may occur when the effects of the drug wear off. Instruct the client on the use of the inhaler, and observe its use. Instruct the client to hold his or her breath for 10 seconds after inhaling the medication and wait for 2 full minutes before the second inhalation. Client education as it relates to beta-adrenergic agonists should include goals, reasons for obtaining baseline data such as vital signs and tests for cardiac and renal function, and possible side effects. The following are important points to include when teaching clients regarding beta-adrenergic agonists. 1. Limit the use of products that contain caffeine. 2. Immediately report difficulty breathing, heart palpitations, tremor, vomiting, nervousness, and vision changes. Next we will discuss a prototype drug salmeterol, marketed as Ceravent Discala Disc. Regarding its actions and uses, salmeterol acts by selectively binding to beta-2 adrenergic receptors in bronchial smooth muscle to cause bronchodilation. When taken 30 to 60 minutes prior to physical activity, it has been shown to prevent exercise-induced bronchospasm. Its 12-hour duration of action is longer than that of many other bronchodilators, thus making it ideal for asthma maintenance therapy. Because salmeterol takes 15 to 25 minutes to act, it is not indicated for the termination of acute bronchospasm. Regarding its pharmacokinetics, there is minimal systemic absorption of salmeterol following inhalation. It has a half-life of 3 to 4 hours. We will now discuss a few administration alerts. 1. Proper use of the dry powder inhaler is important for effective delivery of drug. Observe and instruct the client in proper use. 2. Salmeterol is pregnancy category C, and now we will discuss its adverse effects and interactions. Serious adverse effects from salmeterol are uncommon. Like other beta agonists, some clients experience headaches, nervousness, and restlessness. Because of its potential to cause tachycardia, clients with heart disease should be monitored regularly. Excessive use of salmeterol, more than 3 times per week, for asthma attacks, waking with symptoms, or regular dyspnea are signs of uncontrolled asthma that requires adjustment of medications. Concurrent use of beta blockers will antagonize the effects of salmeterol. We will now look at methylxanthines and anticholinergics. Although beta agonists are drugs of choice for treating acute bronchospasm, drugs in the methylxanthines and anticholinergic classes are alternatives for the treatment of asthma. The methylxanthines are older, established drugs. Only one anticholinergic is in widespread use. These agents are listed in Table 38.2. Treating asthma with methylxanthines and anticholinergics. Methylxanthines and anticholinergics are bronchodilators occasionally used as alternatives to the beta agonists in asthma therapy. The methylxanthines, such as theophylline, marketed as Unifil, or Thiolair, and aminophylline, comprise a group of bronchodilators that are chemically related to caffeine. Theophylline has a narrow margin of safety and interacts with a large number of other drugs. Side effects such as nausea, vomiting, and CNS stimulation are relatively common, and dysrhythmias may be observed at high doses. Because of their chemical similarities, clients should avoid caffeine-containing foods and beverages when taking methylxanthines. These agents are given by the oral or intravenous route. Having been largely replaced by safer and more effective drugs, the current use of theophylline is primarily for the long-term, oral prophylaxis of persistent asthma. Blocking the parasympathetic nervous system produces similar effects to stimulation of the sympathetic nervous system. It is predictable then that anticholinergic drugs would cause bronchodilation and have potential use in the pharmacotherapy of asthma and other pulmonary diseases. Ipratropium, marketed as Atrovent, is the most common anticholinergic prescribed for asthma and chronic obstructive pulmonary disease pharmacotherapy. It has a slower onset of action than most beta agonists and produces less intense bronchodilation. Anticholinergic side effects that are associated with drugs in this class are much milder when the drugs are administered by inhalation rather than systemically. We will now briefly consider a NCLEX success tip. Methyl xanthines such as theophylline are highly potent bronchodilators used to relieve asthma symptoms. The bronchodilation will result in decreased wheezing. Let's now focus on a few nursing considerations. The role of the nurse in asthma therapy with methyl xanthines and anticholinergics involves careful monitoring of the client's condition and providing education as it relates to the prescribed drug regimen. Assess respiration rate before and after the first dose from a metered dose inhaler, because the first dose may precipitate bronchospasm. Monitor vital signs and intake and output throughout therapy, as these drugs cause diuresis. Elderly clients who are using methyl xanthines should be monitored carefully for toxicity, as these clients may exhibit increased sensitivity due to decreased hepatic metabolism. Methyl xanthines may cause dysrhythmias, nausea, vomiting, and irritation of the upper respiratory tract, which may result in cough, drying of mucous membranes, and a bitter taste. To help with dry mouth and bitterness, clients can rinse their mouths frequently or use sugarless, hard candy. Anticholinergic bronchodilators should be used cautiously in elderly men with benign prostatic hypertrophy and in all clients with glaucoma. The complete nursing process applied to clients receiving anticholinergics is presented in Nursing Process Focus, Clients Receiving Anticholinergic Therapy in Chapter 14, page 148. Client education as it relates to methyl xanthines should include goals, reasons for obtaining baseline data such as vital signs and tests for cardiac and renal function, and possible side effects. Instruct the client to immediately report the following: inability to urinate or have a bowel movement, severe headache, heart palpitations, difficulty breathing, changes in vision, and eye pain. For additional nursing considerations, see Nursing Process Focus, Clients Receiving Bronchodilators. We will now briefly consider a NCLEX success tip. Theophylline and other methyl xanthines agents make the central respiratory center more sensitive to carbon dioxide and stimulate the respiratory drive. Inhibition of phosphodiesterase is the drug's mechanism of action in treating asthma and other reversible obstructive airway diseases, not chronic obstructive pulmonary disease. Pause the video and carefully scrutinize Nursing Process Focus before advancing to the next slide. Pause the video and carefully scrutinize Nursing Process Focus before advancing to the next slide. Next we will discuss a few connections, focusing on special considerations. Let's begin with asthma management in schools. Approximately 10% of children have asthma. Researchers suggest that asthma is one of the most common causes of school absenteeism. In a typical class of 30 children or youth, 2 students suffer from asthma attacks each year while at school. Children cannot learn while experiencing wheezing, coughing, and shortness of breath. Assisting schools to develop asthma management programs has become the focus of several federal agencies and dozens of professional and client advocacy groups. Many schools are adopting asthma management plans as part of a coordinated school health program. Schools with these programs have established asthma-friendly policies, such as allowing students to carry and administer quick relief asthma medications. In addition, The schools routinely maintain a copy of the student's asthma action plan from the caregiver or healthcare provider. The role of the school nurse is to review the plan, determine the student's specific needs, and ensure that the student has immediate access to quick relief asthma medication. The optimal plan for each student is determined case by case, with input from the student, parents, healthcare provider, and school nurse. Typically, older students are permitted to carry the inhaler and to self-administer as needed. The nurse often keeps a backup supply of the student's medication. For younger children, a supervised health assistant may be delegated to administer the medication. Pause the video and carefully scrutinize Table 38.3 summarizing anti-inflammatory drugs used for asthma before advancing to the next slide. Next we will discuss a prototype drug ipratropium, marketed as Atrovent. Regarding its actions and uses, ipratropium is an anticholinergic, muscarinic antagonist that causes bronchodilation by blocking cholinergic receptors in bronchial smooth muscle. It is administered via inhalation and can relieve acute bronchospasm within minutes after administration. Effects may peak in 1 to 2 hours and continue for up to 6 hours. Ipratropium is less effective than the beta-2 agonists, but is sometimes combined with beta-agonists or glucocorticoids for its additive effects. It is also prescribed for chronic bronchitis and for the symptomatic relief of nasal congestion. Regarding its pharmacokinetics, there is minimal systemic absorption of ipratropium following inhalation. It has a half-life of 2 hours. And now we will discuss a few administration alerts. 1. Proper use of the metered dose inhaler is important for effective delivery of the drug. Observe and instruct the client in proper use. 2. Avoid contact with eyes. 3. Ipratropium is pregnancy category B adverse effects and interactions. Because it is not readily absorbed from the lungs, ipratropium produces few systemic side effects. Irritation of the upper respiratory tract may result in cough, drying of the nasal mucosa, or hoarseness. It produces a bitter taste, which may be relieved by rinsing the mouth after use. We will now briefly consider a NCLEX success tip. Ipratropium is a bronchodilator, and its anticholinergic effects can aggravate urine retention. Next we will discuss glucocorticoids. Inhaled glucocorticoids are used for the long-term prevention of asthma attacks. Oral glucocorticoids may be used for the short-term management of acute asthma. The glucocorticoids are listed in Table 38.3. We will now look at pharmacotherapy of asthma with glucocorticoids. Inhaled glucocorticoids are first-line therapy for asthma. They reduce inflammation and provide long-term prophylaxis of attacks. Oral glucocorticoids are also available. Glucocorticoids are first-line therapy for the pharmacotherapy of asthma. When inhaled on a daily schedule, these hormones suppress airway inflammation without major side effects and help to prevent acute asthma attacks. Clients should be informed that inhaled glucocorticoids must be taken daily to produce their therapeutic effect, and that these drugs are not effective at terminating episodes in progress. For some clients with mild, persistent asthma who do not wish to take inhaled steroid therapy daily, an as-needed treatment strategy may be acceptable provided that it is accompanied by education and an action plan with clear instructions about how and when to increase medication use. Nevertheless, daily inhaled steroid treatment remains the preferred evidence-based therapy for asthma. For severe, persistent asthma that is unresponsive to other treatments, oral glucocorticoids may be prescribed. If taken for longer than 10 days, oral glucocorticoids can produce significant adverse effects, including adrenal gland atrophy, peptic ulcers, and hyperglycemia. Other uses and adverse effects of glucocorticoids are presented in Chapter 30. We will now progress to discuss a few nursing considerations. The role of the nurse in asthma pharmacotherapy with glucocorticoids involves careful monitoring of the client's condition and providing education as it relates to the prescribed treatment. Assess the client for the presence or history of asthma, seasonal rhinitis, hypertension, heart disease, and blood clots. Monitor the client's vital signs and body weight, and assess for signs and symptoms of infection. The steroid inhalers should be used cautiously in clients with hypertension, gastrointestinal disease, congestive heart failure, or thromboembolic disease. Because the primary purpose of inhaled glucocorticoids is to prevent respiratory distress, the client should be advised that this medication should not be used during an acute asthma attack. Excessive use of a short-acting bronchodilator, i.e. more than 3 times per week, for acute asthma attacks, waking with symptoms, or regular dyspnea are signs of uncontrolled asthma that require adjustment of the glucocorticoid dosage. In addition, the client should be alert for signs and symptoms of simple infections, as glucocorticoids inhibit the inflammatory response and can mask the signs of infection. The client should be advised to rinse the mouth after using steroid inhalers because the drugs may promote fungal infections of the mouth and throat. Glucocorticoids also increase blood glucose levels and should be closely monitored in individuals with diabetes mellitus. Client education as it relates to glucocorticoids should include goals, reasons for obtaining baseline data such as vital signs and tests for cardiac and renal function, and possible side effects. The following are the important points to include when teaching clients regarding glucocorticoids. 1. Monitor temperature and blood pressure daily and report elevation to the healthcare provider. 2. If diabetic, monitor blood glucose level closely and report unexplained or consistent elevations. 3. Report occurrence of tarry stools, edema, dizziness, or difficulty breathing. 4. Do not use these medications to terminate acute asthma attacks. Discuss with the healthcare provider the appropriate medication to stop attacks. Next we will look at a prototype drug beclomethasone, marketed as QVAR. Regarding its actions and uses, beclomethasone is a glucocorticoid available through aerosol inhalation, using a metered dose inhaler, for asthma or as a nasal spray for allergic rhinitis. For asthma, 2 inhalations, 2 to 3 times per day, usually provide adequate prophylaxis. Beclomethasone acts by reducing inflammation, thus decreasing the frequency of asthma attacks. It is not a bronchodilator and should not be used to terminate asthma attacks in progress. Regarding its pharmacokinetics, there is minimal systemic absorption of beclomethasone when inhaled. It has a half-life of 1.5 hours. And now we will look at a few administration alerts. 1. Do not use if the client is experiencing an acute asthma attack. 2. Oral inhalation products and nasal spray products are not to be used interchangeably. 3. Beclomethasone is pregnancy category C, and now let's discuss its adverse effects and interactions. Inhaled beclomethasone produces few systemic side effects. Because small amounts may be swallowed with each dose, the client should be observed for signs of glucocorticoid toxicity when taking the drug for prolonged periods. Local effects may include hoarseness of the voice. Like all glucocorticoids, the anti-inflammatory properties of beclomethasone can mask signs of infection, and the drug is contraindicated if active infection is present. A large percentage of clients who take beclomethasone on a long-term basis will develop candidiasis, a fungal infection in the throat, due to the constant deposits of drug in the oral cavity. Next we will discuss mast cell stabilizers. Two mast cell stabilizers serve limited though important roles in the prophylaxis of asthma. The mast cell stabilizers act by inhibiting the release of histamine from mast cells. These drugs are listed in Table 38.3. Let's now switch gears to treating asthma with mast cell stabilizers. Cromolyn, a mast cell stabilizer, is a safe drug used for the prophylaxis of asthma, but it is ineffective at relieving acute bronchospasm. Cromolyn is classified as mast cell stabilizers because its action serves to inhibit mast cells from releasing histamine and other chemical mediators of inflammation. By reducing inflammation, it is able to prevent asthma attacks. As with the glucocorticoids, clients must be informed that this agent should be taken on a daily basis and that it is not effective at terminating acute attacks. Maximum therapeutic benefit may take several weeks. Cromolyn is pregnancy category B. Cromolyn was the first mast stabilizer discovered. When administered via an metered dose inhaler or a nebulizer, this drug is a safe alternative to glucocorticoids. An intranasal form of cromolyn is used in the treatment of seasonal allergies. Side effects include stinging or burning of the nasal mucosa, irritation of the throat, and nasal congestion. Although not common, bronchospasm and anaphylaxis have been reported. Because of its short half-life, that is 80 minutes, it must be inhaled 4 to 6 times per day. And now we will shift gears to leukotriene modifiers. The leukotriene modifiers are newer drugs, approved in the 1990s, that are used to reduce inflammation and ease bronchoconstriction. They modify the action of leukotrienes, which are mediators of the inflammatory response in asthmatic clients. These drugs are listed in Table 38.3. Let's now discuss treating asthma with leukotriene modifiers. The leukotriene modifiers, whose primary use is in asthma prophylaxis, act by reducing the inflammatory component of asthma. Leukotrienes are mediators of the immune response that promote airway edema, inflammation, and bronchoconstriction. Xileuton, marketed as Zyflo, acts by blocking lipoxygenase, the enzyme that converts arachidonic acid into leukotrienes. The remaining two agents in this class, zafirleucast, marketed as Accolate, and monteleucast, marketed as Singulair, act by blocking leukotriene receptors. The leukotriene modifiers are approved for the prophylaxis of chronic asthma. They are not bronchodilators and are ineffective in terminating acute asthma attacks. They are all given orally. Because Xileuton is taken 4 times a day, it offers less client convenience than monteleucast or zafirleucast, which are taken every 12 hours. Xileuton has a more rapid onset of action, that is 2 hours, than the other two leukotriene modifiers, which take as long as 1 week to obtain therapeutic benefit. Few serious adverse effects are associated with the leukotriene modifiers. Headache, cough, nasal congestion, or gastrointestinal upset may occur. Clients older than age 55 must be monitored carefully for signs of infection because these clients have been found to experience an increased frequency of infections when taking leukotriene modifiers. These agents may be contraindicated in clients with significant hepatic dysfunction or chronic alcoholism because they are extensively metabolized by the liver. Next we will discuss common cold. The common cold is a viral infection of the upper respiratory tract that produces a characteristic array of annoying symptoms. It is fortunate that the disorder is self-limiting because there is no cure or effective prevention for colds. Therapies used to relieve symptoms may include the same classes of drugs used for allergic rhinitis, Chapter 42, such as antihistamines, decongestants, and additional drugs such as those that suppress cough and loosen bronchial secretions. We will now look at pharmacotherapy with antitussives. Antitussives are effective at relieving cough due to the common cold. Opioids are used for severe cough. Non-opioids such as dextromethorphan are used for mild or moderate cough. Antitussives are drugs used to dampen the cough reflex. They are of value in treating coughs due to allergies or the common cold. Cough is a natural reflex mechanism that serves to forcibly remove excess secretions and foreign material from the respiratory system. In diseases such as emphysema and bronchitis, or when liquids have been aspirated into the bronchi, it is not desirable to suppress the normal cough reflex. Dry, hacking, non-productive cough, however, can be quite irritating to the membranes of the throat and can deprive a client of much-needed rest. It is this type of situation in which therapy with antitussives may be warranted. Antitussives are classified as opioids or non-opioids and are listed in Table 38.4. Opioids, the most efficacious antitussives, act by raising the cough threshold in the CNS. Codeine and hydrocodone, marketed as Hydocon, are the most frequently used opioid antitussives. Doses needed to suppress the cough reflex are very low, so there is minimal potential for dependence. Most opioid cough mixtures are classified as Schedule 3, 4 or 5 drugs and are reserved for more serious cough conditions. Although not common, overdose from opioid cough remedies may result in significant respiratory depression. Care must be taken when using these medications in clients who have asthma or allergies since bronchoconstriction may occur. Opioids may be combined with other agents such as antihistamines, decongestants, and non-opioid antitussives in the therapy of severe cold or flu symptoms. Some of these combinations are shown in Table 38.5. The most frequently used non-opioid antitussive is dextromethorphan, marketed as Cofex-DM. At low doses, this drug is available in over-the-counter cold and flu medications. Higher doses are available by prescription to treat more severe cough. Dextromethorphan is chemically similar to the opioids and also acts in the CNS to raise the cough threshold. Although not as efficacious as codeine, there is no risk for dependence with dextromethorphan. Benzonatate is a non-opioid antitussive that acts by a different mechanism. Chemically related to the local anesthetic tetracaine, benzonatate suppresses the cough reflex by anesthetizing stretch receptors in the lungs. If chewed, the drug can cause the side effect of numbing the mouth and pharynx. Side effects are uncommon but may include sedation, nausea, headache, and dizziness. Pause the video and carefully scrutinize Table 38.4 summarizing agents for the common cold and removal of excessive bronchial mucus before advancing to the next slide. Pause the video and carefully scrutinize Table 38.5 summarizing opioid combination drugs for severe cold symptoms before advancing to the next slide. We will now progress to a few nursing considerations. The role of the nurse in antitussive therapy involves careful monitoring of the client's condition and providing education as it relates to the prescribed drug regimen. The nursing care related to clients who are receiving antitussive drugs is dependent on the agent used. For all antitussive drugs, assess the client for the presence or history of persistent non-productive cough, respiratory distress, shortness of breath, and productive cough. When codeine or other opioids are prescribed, the client should be monitored for drowsiness. Because cough is a protective mechanism used to clear the lungs of microbes, Antitussive drugs should be used in moderation and only to treat cough when it interferes with activities of daily living, rest, or sleep. Extreme caution should be used when administering antitussive drugs to individuals with chronic lung conditions, as normal respiratory function is already impaired. Because cough may be a symptom of other serious pulmonary conditions, antitussive drugs should be used for only 3 days, unless otherwise approved by the healthcare provider. Client education as it relates to antitussives includes goals, reasons for obtaining baseline data such as vital signs and tests for cardiac and renal function, and possible side effects. The following are the specific points to include when teaching clients regarding antitussives. 1. Avoid driving and performing hazardous activities while taking opioid antitussives. 2. Avoid use of alcohol, which can cause increased CNS depression. 3. Immediately report the following: coughing up green or yellow-tinged secretions, difficulty breathing, excessive drowsiness, constipation, and nausea or vomiting. 4. Store opioid antitussives away from children. Next we will discuss a prototype drug dextromethorphan, marketed as Cough-XDM. Regarding its actions and uses, dextromethorphan is a drug included in most cold and flu preparations. It is available in a large variety of formulations, including tablets, liquid-filled capsules, lozenges, and liquids. Like codeine, it acts in the medulla, though it lacks the analgesic and euphoric effects of the opioids and does not produce dependence. Clients whose cough is not relieved by dextromethorphan after several days of therapy should see their healthcare provider. Regarding its pharmacokinetics, dextromethorphan is rapidly absorbed from the gastrointestinal tract, with an onset of action usually within 15 to 30 minutes. It crosses the blood-brain barrier and placenta and enters breast milk. Dextromethorphan and its active metabolite, dextrorphan, are excreted in urine. Its half-life is unknown. Next we will look at a few administration alerts. 1. Avoid pulmonary irritants, such as smoking and other fumes, as these agents may decrease drug effectiveness. 2. Dextromethorphan is pregnancy category C. Next we will discuss its adverse effects and interactions. Side effects due to dextromethorphan are rare. Dizziness, drowsiness, and gastrointestinal upset occur in some clients. Drug interactions with dextromethorphan include a high risk for excitation, hypotension, and hyperpyrexia when used concurrently with monoamine oxidase inhibitors. Concurrent use with alcohol may result in increased CNS depression. Next we will discuss pharmacotherapy with expectorants and mucolytics. Expectorants promote mucus secretion, making the mucus thinner and easier to remove by cough. Mucolytics are agents used to break down thick bronchial secretions. Certain drugs are available to control excess mucus production. Expectorants increase bronchial secretions, and mucolytics help to loosen thick bronchial secretions. These agents are listed in Table 38.4. Expectorants are drugs that increase bronchial secretions. They act by reducing the thickness, or viscosity, of bronchial secretions, thus increasing mucus flow so that the mucus can more easily be removed by coughing. The most effective over-the-counter expectorant is guaifenesin, marketed as Benylin, or Balmonal. Like dextromethorphan, guaifenesin produces few adverse effects and is a common ingredient in many over-the-counter cold and flu preparations. Higher doses of guaifenesin are available by prescription. Mucolytics are drugs used to break down the chemical structure of mucus molecules. Mucolytics cause thick, viscous bronchial secretions to become thinner and more able to be removed by coughing. Acetylcysteine, marketed as Mucomist, one of the few mucolytics available, is delivered by the inhalation route and is not available over the counter. It is used in clients who have cystic fibrosis, chronic bronchitis, or other diseases that produce large amounts of thick bronchial secretions. Another mucolytic, Dornase alpha, marketed as Pulmozyme, is used to break down DNA molecules in thick bronchial mucus, causing it to become less viscous. We will now look at chronic obstructive pulmonary disease. Chronic obstructive pulmonary disease, abbreviated as COPD, is a generic term used to describe several pulmonary conditions characterized by cough, mucus production, and impaired gas exchange. Drugs may be used to bring symptomatic relief, but they do not cure the disorders. Next we will shift gears to pharmacotherapy of chronic obstructive pulmonary disease. Chronic obstructive pulmonary disease is a progressive disorder treated with multiple pulmonary drugs. Bronchodilators, expectorants, mucolytics, antibiotics, and oxygen may offer symptomatic relief. Chronic obstructive pulmonary disease is a major cause of death and disability. The three specific chronic obstructive pulmonary disease conditions are asthma, chronic bronchitis, and emphysema. Chronic bronchitis and emphysema are strongly associated with smoking tobacco products and, secondarily, with breathing air pollutants. In chronic bronchitis, excess mucus is produced in the bronchial tree due to inflammation and irritation from tobacco smoke or pollutants. The airway becomes partially obstructed with mucus, thus resulting in the classic signs of dyspnea and coughing. An early sign of bronchitis is often a productive cough that occurs upon awakening. Wheezing and decreased exercise tolerance are additional clinical signs. Because microbes enjoy the mucus-rich environment, pulmonary infections are common. Gas exchange may be impaired. Chronic obstructive pulmonary disease is progressive, with the terminal stage being emphysema. After years of chronic inflammation, the bronchioles lose their elasticity and the alveoli dilate to maximum size. The bronchioles collapse during exhalation, which restricts airflow and traps air in the lungs. The client suffers extreme dyspnea from even the slightest physical activity. Clients with chronic obstructive pulmonary disease may receive a number of pulmonary drugs for symptomatic relief. The goals of pharmacotherapy are to treat infections, control cough, and relieve bronchospasm. Most clients receive bronchodilators such as anticholinergics, beta-2 agonists, or inhaled glucocorticoids. Mucolytics and expectorants are sometimes used to reduce the viscosity of the bronchial mucus and to aid in its removal. Oxygen therapy assists breathing in emphysema clients. Antibiotics may be prescribed for clients who experience multiple bouts of pulmonary infection. Clients should be taught to avoid taking any drugs that have beta antagonist activity or otherwise cause bronchoconstriction. Respiratory depressants such as opioids and barbiturates should be avoided. It is important to note that none of the pharmacotherapies offer a cure for chronic obstructive pulmonary disease. They only treat the symptoms of a progressively worsening disease. The most important teaching point for the nurse is to strongly encourage smoking cessation in these clients. Next we will look at a few connections, focusing on special considerations. Let's look at respiratory distress syndrome. Respiratory distress syndrome, abbreviated as RDS, is a condition, primarily occurring in premature babies, in which the lungs do not produce surfactant. Surfactant forms a thin layer on the inner surface of the alveoli to raise the surface tension. This prevents the alveolus from collapsing during expiration. If birth occurs before the pneumocytes in the lung are mature enough to secrete surfactant, the alveoli collapse and respiratory distress syndrome results. Surfactant medications can be delivered to the newborn either as prophylactic therapy or as rescue therapy after symptoms develop. The two surfactant agents used for respiratory distress syndrome are colfosirol and Baractant, marketed as Savanta. These drugs are administered intratracheally every 4 to 6 hours, until the client's condition improves. Finally, we will look at understanding the chapter, focusing on a key concept summary. The numbered key concepts provide a succinct summary of the important points from the corresponding numbered section within the chapter. If any of these points are not clear, refer to the numbered section within the chapter for review. 38.1. The physiology of the respiratory system involves two main processes. Ventilation moves air into and out of the lungs, and perfusion allows for gas exchange across capillaries. 38.2. Bronchioles are lined with smooth muscle that controls the amount of air entering the lungs. Dilation and constriction of the airways are controlled by the autonomic nervous system. 38.3. Inhalation is a common route of administration for pulmonary drugs because it delivers drugs directly to the site of action. Nebulizers, metered-dose inhalers, and dry powder inhalers are devices used for aerosol therapies. 38.4. Asthma is a chronic disease that has both inflammation and bronchospasm components. Treatment should focus on the reduction of inflammation. Environmental control can help to reduce inflammation and prevent asthma attacks. 38.5. Beta-adrenergic agonists are the most effective drugs for relieving acute bronchospasm. These agents act by activating beta-2 receptors in bronchial smooth muscle to cause bronchodilation. 38.6. Methylxanthines and anticholinergics are bronchodilators occasionally used as alternatives to the beta agonists in asthma therapy. 38.7. Inhaled glucocorticoids are first-line therapy for asthma. They reduce inflammation and provide long-term prophylaxis of attacks. Oral glucocorticoids are also available. 38.8. Cromolyn, a mast cell stabilizer, is a safe drug used for the prophylaxis of asthma, but it is ineffective at relieving acute bronchospasm. 38.9. The leukotriene modifiers, whose primary use is in asthma prophylaxis, act by reducing the inflammatory component of asthma. 38.10. Antitussives are effective at relieving cough due to the common cold. Opioids are used for severe cough. Non-opioids such as dextromethorphan are used for mild or moderate cough. 38.11. Expectorants promote mucus secretion, making the mucus thinner and easier to remove by cough. Mucolytics are agents used to break down thick bronchial secretions. 38.12. Chronic obstructive pulmonary disease, abbreviated as COPD, is a progressive disorder treated with multiple pulmonary drugs. Bronchodilators, expectorants, mucolytics, antibiotics, and oxygen may offer symptomatic relief. Welcome to this video entitled, Pharmacotherapy in Substances of Abuse and Addiction.